Hello, hi, good evening, ladies and gentlemen. It will be a great pleasure to be part of. I'm currently on vacation, so this is the time period where all the Swiss families basically are on vacation, and I could manage to make this lecture because it was for me very important to be part here in Hong Kong. I would like to thank you very much for the invitation, and I'm really excited to share with you the presentation. Let me check. I have now. So. Okay.
Prof, you can share your screen. Can you hear me now? Yep.
Can you see me again? Can you hear me?
Thank you.
Okay. Can you see the screen as well?
Yep. Can. No problem.
Perfect. So today I'm very happy to share with you and very excited to share with you something which I think is really revolutionized dentistry in a way from an implant prosthetic. And today I would like to go and build up kind of the whole complex situation of the today's prosthetic situation and provide us with new solutions for a digital and completely personalized way. So this is the view at the Lake of Zurich on a sunny day. And I live here on the left-hand side here on the coast. And this gentleman here, his name is Steve, and he also lives here at the same area as I grew up there. And Steve became over the years a very successful wakeboarder. But at one time, he went to Florida, because in Florida, in order to do wakeboarding, you have the completely flat lakes there. And that's where they can really save their weight in order to really make their amazing jumps. And so Steve lives from that moment on now in Florida. But at one day, Steve had really a very bad day. And he during a jump, he hit his board into the face and ended up by having lost the center incisor and the lateral incisor. Now, for those of you which are also prosthodontists, you know how difficult actually this always is when we have one side which is completely perfect and the other side which is considered to be really deficient. So in order to get to a result like this, when we start with a really vertical and horizontal deficiency and being able to solve this problem like this, we need to ask ourselves, how can we be successful? How do we achieve this result? And over the years, I realized that the most important part in dentistry is about taking the right decisions. It's not just about using the right techniques. It's really that you're going to take the right decisions. And these decisions need to be taken also by Steve. He needs to think of which kind of boat he's going to take. He needs to think how he's going to shape the wave, and he's going to select about which boat he's going to use. Now, for us as dentists, we have a variety of different situations here, from single tooth to multiple tooth care. And number one, I think it's a very important information that implant prosthetics is strongly linked to the teamwork with the dental technician. So this is always a very strong team approach. And at the end, we need to make decisions also about the different components, different materials, and also about the different workflows we have available. So when we would like to be really successful in implant dentistry and in specific in implant prosthetics, we need to take the right decisions on the level of the abutment or the prosthetic situation. And there are basically four factors which are influence this. Number one, it's the safety. Number two, it's kind of how efficient are we. Number three, it's the material properties which we need to be aware of. And number four, it's the aesthetic outcomes which we need to take up. Now let's go through each of these different parameters. Parameter number one, about the clinical decisions. So here, this is a lady which was working at the University Hospital in Zurich. She's not that tall, but she's really heavy and strong. And she came with a complete collapse of her bite. You could see here, there's basically, she's biting here into the gum. So she really wanted to close their diastemas and she wanted to have teeth again in their back part. But unfortunately, she had very little money. Therefore, this lady was treated within the student course at the University of Zurich. And in order to have a very kind of cost-effective treatment, all the teeth in the front have been restored with composite in order to make them, to close the gaps there, which that's why they don't look that perfect. And in the posterior area, they made implants and they used zirconia crowns, which were veneered. Now, only 4 months later, she came to the University Hospital and said, listen, it's kind of rough there when I touch with my tongue in this area here. And when we look here on the occlusal view, we see that we have a lot of different chippings here in these teeth. So the patient was told, listen, we need to remove these crowns, and these crowns have been cemented. So there was an access hole which was drilled here, and then later on the implant crowns could be removed. And you could see we have here used individual zirconia abutments. And this has been done in the student course, ladies and gentlemen. And what we see here are a lot of remaining cement. So also under ideal conditions in the student course, where they have plenty of time, there is remaining cement there. So this was a surprise. We didn't expect that at all. So that means when we're going to place an implant, going to place it 2 millimeters subgingially, we can easily be additional 7 millimeters in the mesodistal part. And this brings up the question, how effectively can we really remove cement? Now, this was, for me, a very nice study from John Ager, a famous professor from the US, which did a very simple study. He asked clinicians to remove 3 different cements from a clinically analog model, where the margins are placed 1.5 to 3 millimeters subgingially. And after this clinician have removed the cement, he microscopically assessed then the remaining cement of the implant surface. What did he find out? He found out the more sticky the cement are, the more cement is still there after removing. But now, ladies and gentlemen, you need to face this point. In none of the cases it was possible to completely remove cement on a level of 1.5 to 3 millimeters. So also under ideal conditions on a model, we are not able to remove cement, which is below 1.5 to 3 millimeters. And this has also been further confirmed by different clinical studies, also from Thomas Linkevicius. So is remaining cement a clinical problem? When we look at this case, it's an old case from our postgraduate clinic where a zirconia abutment has been placed, and this is the control X-ray before cementation. Then here the clinical picture, and here after cementing the crown. So the postgraduate student was very proud on this result, and I think it looks very nice. Also color-wise, it looks very nice. So the postgraduate student was looking forward to see the patient later on for a control. And then patient came back 2 months later, and then he said, what is going on here? Why do we see so much inflammation there? So he thought, let's do an X-ray. And in the X-ray, you could see that we have along the entire abutment, including on the screws of the implant, we have remaining cement. So he thought, don't tell anybody. Let's try to remove it secretly, and then nobody will ever find it out. So he didn't tell anybody of the faculty. He opened the flap and he removed the cement. But then 10 months later, the patient came back, and look what happened. We still have cement here, and we have a complete loss of the bone, which at the end, we had to remove the implant. And we had to remove the implant just because of the wrong decision in time of implant prosthetics. So are cemented reconstruction not as safe as screw-retained reconstruction? When we go into the literature, we have now a kind of a strong body of literature which tells us that cemented reconstruction exhibited more biologic complications with bone loss more than 2 millimeters. And on the other hand, screw-retained reconstructions exhibit more technical complications, but they're easy to be handled because it's you can retrieve it, and they have no biologic consequence. So screw-retained reconstructions seem really to be preferable in this here, and cemented reconstruction might not be as safe as screw-retained reconstruction. So when we conclude about the safety, we can say cement removal of implant reconstruction with margin located between 1.5 to 3 millimeters subject cannot be performed to 100%. That's a very important message you should not forget. Number two, we have learned from Tom Wilson from Dallas that excess dental cement was associated with signs of peri-implant disease in the majority of the cases, in 81% of the cases. And cemented reconstruction exhibited more biologic complications, whereas screw-retained reconstruction exhibited more technical complications, which were not as bad. So that's number one when it comes to safety. Now, what about the efficiency? What about the different workflows? And what about comparing the digital workflow with the conventional workflow? And I would like to start with you again with a clinical case. This lady here, she came to me in February 2019. She's actually a famous actress, and she has been treated by one of the most well-known dentists worldwide. It's a dentist which places about 1,500 implants a year, and is super experienced. And when I would tell you the name, many of you might know his name. But this was the situation after implant placement. And she came to me like this, and she said, listen, in 2 months, my film is nominated as one of the important movies at the film festival in Cannes in France. And by then, I need to look perfect. So 2 months would be time to do this. Then I told her, listen, within 2 months, it's impossible to do anything in this situation. So when we analyze the situation, there are 2 implants which have been placed as immediate implants. You could say maybe they are a little bit close together. But an additional problem was the fact that we really have an implant which is placed outside the bony envelope. And this has been placed by somebody which is very experienced, ladies and gentlemen, somebody which places more than 1,500 implants a year. So I told her, listen, I cannot fix that within 2 months. But what I can do is I can remove the crowns, let it heal, and then provide you with a removable provisional prosthesis. Because she needed and she wanted to have this diastema situation. So that's why it was not possible to provide her with a resin bonded bridge. So this is basically how she left Zurich and then flew to the Cannes Film Festival in France. Now, in France, the man here in the center with the yellow jacket, he's the film director and he's from Argentina. And he's a very provocative film director. So he decided that she's not allowed to wear the temporary prosthesis during the whole festival. So you can imagine in a festival where there's just beautiful people and one person doesn't wear a temporary reconstruction, has no teeth, that created a lot of attention. That's how she gave the media conference, the official one, without the teeth. So this created a big noise all over the world and also in Switzerland by having having multiple reports about her. Luckily, she never told the people that I'm her dentist, because otherwise I would have been ruined. Now, this is the situation, and this was the situation before the tooth has been extracted. It was a fractured tooth. So it is a delicate situation, ladies and gentlemen. But again, it is not enough to have sufficient experience when it comes to the decision whether we're going to go for a digital workflow or a conventional workflow. Many of the experienced dentists say, listen, I don't need to have this digital workflow. It takes me too much time. And I did that for years like this. Yes, I agree. But that was for us a really motivation to see what is the time difference between the digital workflow and the conventional workflow. And that means that it's on different levels, from the digital diagnostics over the implantation until the prosthetic reconstruction. Starting with the clinical diagnostics, we did 4 randomized controlled studies, and there was a lot of effort to do them, and they were led by David Schneider, a former faculty of our clinic. And we evaluated a variety of parameters, and we also put the big focus on the duration. Now, 75 patients with single and multiple gaps have been included in the study. Only 1 study implant was allowed per patient. Then we had 25 in the control, 25 in the test group, and then also 25 in the second test group. Test group 1 was using a stent which has been used industrially, and test 2 is using a stent which has been printed within the University of Zurich. Now, what were the results for the clinical diagnostics and the prosthetic planning? That was the first surprise. There was basically no difference between different workflows. So we don't gain time with digital workflow. Now, how does the future look like in this situation when it comes to diagnostics? Because we can see we don't gain time through doing this exercise. So we could reduce the amount of time by reducing the amount of steps necessary for being in the virtual reality and for being then in the reality. And today, tools for augmented reality and also the full digital workflow by the patient is capable of keeping the workflow more within the digital environment, which helps us as dentists to save time. Now, what are the limitations of a pure digital diagnostic? So when we do these diagnostics with these fancy tools, are there any disadvantages? I would like to show you here a situation of a patient which was originally treated in Amsterdam, in a also famous office there with a good dentist and good dental technician. And she called me before Christmas and said, listen, I need to see you. I hate my teeth, and I really wanna hit my teeth out of my mouth. So she came to me. She said, I want to have a hammer and knock my teeth out. She doesn't talk anymore. She really fall into a depression. So she looked very unhappy. That was the clinical situation, and there was the anterior situation where we have 1 implant and then for 5 veneers. Now, the patient was very unhappy. And when you look at her, I think many of you will say, yes, I think she has nice teeth. She has here kind of an excess part, but at the end of the day, she has actually nice teeth. So for her, it was clear she hates the teeth. Now, why does she hate her teeth so much when the situation is not so bad? And why is she in a depression? Why feels she totally down in this process? Why does the patient feel so down? When we look at the situation and try to summarize what happened regarding the initial examination and the communication between the patient and the dentist, then number 1, the dentist never asks the patient what she actually wants. Never. The diagnostics was only performed on a model virtually, and she could never try it in or take it home. The patient did not got the provisional reconstruction, so he never could test it out. And the dental technician always told her when she wanted to bring herself in, I know exactly what fits you. So nobody was really taking care of her. So when you look at this, we can say this is the complete mismatch of expectations between the dentist, the dental technician, and the patient, because they never talk to each other. And that means, yes, digital communication is important and it helps us for a screening. Like here, for this lady, where we got a little bit an idea what she actually wants regarding the tooth form. But what we also want is a so-called touching communication. That means the patient can really look at it by himself, by herself, and can take it home. And because looking at the mock-up just in the office gives the problem that the patients, hello? That the patient doesn't feel comfortable, he's stressed maybe in the dental environment. The patient needs to see it in his own environment at home. So therefore, the digital mock-ups are super in order to get a first idea about how it looks like. But then later on, we do want to have a mock-up to go. Now, what about the conventional and the digital workflow for the implantation? When we also look here, based on a single X-ray, on a single implant, there is no difference between the different between the different workflows. But the more implants are placed, the more time we save by using a guided workflow. And when we go back to the situation of this actress, the dentist said it's too much effort and too much time I use for doing that. But when you look at this situation in a flapless environment, there is no way, ladies and gentlemen, they're not going through a cone beam CT in order to place the implant. And here you can see I had to remove the implant. This was the situation then. And I had to remove these two implants. In the same appointment, I placed two new implants with a guide where I really could properly transfer the information from my planning into the patient's mouth. And this was the situation after implant placement. Then by using temporary reconstruction, and here was again a discussion whether we close the gaps or not, but she does not want to keep she does not want to close the diastema because she wanted to keep it as it is. And this is the final reconstruction here in place. And this is how we have started. So we have been able to manage really the situation in a nice way, and she could keep her style. And we could really increase the vertical discrepancy. So when we look at the patient, how she was in Cannes in 2020, and this situation in 2021, where she could smile again, where she had exactly her style with the diastema there. So this is about the implantation. And again, to emphasize how important it is to do a digital planning before implantation, especially for immediate implant placement. And then finally, about the comparison between the digital conventional workflow with different studies. We have a randomized controlled study evaluating the effect of digital and conventional workflows for the fabrication of titanium disilicate single crowns, part 1, digital visualization versus conventional impression. Then we had other randomized controlled trial looking at that. But let's look at the first one. And here we also looked at different parameters, and we also looked at the time where it is needed. And here we looked at 10 patients which receive, each of the patients receives 5 monolithic all-ceramic crowns in a posterior mandible. And we used the LAVA scanner, the iTero scanner, the CEREC scanner, and compared to conventional workflow. And we fabricated 5 different crowns out of this workflow. So when we go back to that, we haven't seen any, no. So when we go back, we haven't seen any difference on a dentist level, but we have seen significant difference in the gray part, which is the laboratory work. So the digital workflow primarily helps the dental technician to save significant amount of time, whereas the dentist does not really profit from this time benefit. So when we talk about the efficiency, on the one hand, we can say that computer-assisted protocol reveal longer surgical planning time and longer surgical sprint compared to conventional workflows. However, they did not show an advantage over they did show an advantage when it comes to multiple teeth. The conventional impressions were more time efficient than digital impressions in the patient's way, but we can speed up the process because the ones which profit most from this workflow are at the end dental technician. So this is something which we have to keep in mind. Digital workflow does not primarily really change our workflow completely from a time point of view, but it saved a lot of time with the later on idea with the fabrication of the crown in the dental laboratory. So then another important aspect are the material properties. And here also I would like to share with you a case, maybe one of my most challenging cases I've ever treated. It is Miriam. Miriam, it's a horse addict, and she has 3 own horses, and she does horseback riding in a competitive way. And at one day, there was also her blackest day in her life, where she had an accident. She fell from the horse, and then the horse was standing with the horseshoe on her face. And this ended up by having a significant fracture of the upper jaw, with a complete loss of the bone here, a fracture of the lower jaw, and really a major defect in this area. So after this initial treatment in Great Britain, she came back to Switzerland, and her father is a dentist and she's a dental hygienist. And they said, listen, Ronnie, we want to have the best solution here. So when we look at the situation, it's again, everything about the decision-making process in order to transfer this very complex case into a successful case like here. And this decision is not just one single decision. These are multiple decisions on a multidisciplinary level, from the initial examination to the final reconstruction. And here we have a variety of steps which needs to be done. Number one is the diagnostic part, which can be digitally or analog. Then we have orthodontics, because I was forcing the orthodontist to move the left incisor over the midline. And then the primary bone augmentation procedure took place, where subsequently the implant placement and soft tissue management were addressed. Now, starting with the diagnostic part. This is how it can look like in a virtual environment when we create kind of a digital workflow, where we can superimpose then the different areas, and based on that, we can start bringing the bone situation and the face and the bone into the same context. Now, the next part of the diagnostic was the orthodontic treatment. That was the part which took a lot of time for me, because this left center incisor was also fractured to the midline. So we could not keep that tooth. So before extracting the tooth, I thought that tooth can help me to solve the problem in this area. Because here, this is the most difficult part, having then everything in implants to have this central papilla. So the idea was to move this tooth over on the position of the other center incisors, and then we are going to extract the left center incisor. So here we could easily see how the bridge has been moved on the side, and we could see that this was about almost 1.5 to 2 years which took place in order to get that done. And then the big challenge was always being able to provide it with a good temporary solution, because actually every minute there was another position. And she was working as a dental hygienist, so she said she got a lot of credit from her patients, what she undergoes. And during exactly that time period, also her boyfriend left her. So she was totally disappointed. However, you can see here what we have achieved with bringing that central incisor over the midline. And then I have here a nice place to place a new implant. When we can see here the situation, and the big advantage is that before we had a kind of a large defect in two areas. On the one hand, in the most anterior area, but also then in the posterior area. And we could reduce these through this orthodontic movement on the one hand of number 6 to position number 7, from 7 to number 6, and in the anterior part where we move the central incisor over the midline. So we had now done initial examination, diagnosis, and orthopedics, and now the bone restoration takes place. Now the maxillofacial surgeon, they anyway like to place large grafts, but that's not what we want. We want exactly the right amount. And we did then an implant placement. And for her, it was very important to place each implant at the individual position that she can floss around each implant as the dental assistant. So there are more implants placed than I thought. Then we did a contour augmentation with collagen. And at the end, we closed the flap there. Now, the last part is then the soft tissue management part. Here's the situation after implant placement and additional contour augmentation. I think we have an excellent bone contour, but we still lack a little bit of soft tissue contour. So that means that we need to increase, on the one hand, the amount of keratinized tissue, but on the other hand, also increase the thickness of the soft tissue. So for that purpose, we harvested the graft from the pellet. So I took it in this shape that we have the ends being able to be closed. As you can see it here, it's important that we don't do elevate here the area of the papilla, because that can create some recessions. And then after placing the graft, we sutured the graft, and the healing was really perfect. And then after that, we could start conditioning the soft tissue. Compare where we started, go where we have it ended. And then last but not least, it's about the mechanical stability of ceramic abutments and ceramic crowns. When we have a situation like this, we basically have three options. We have a ceramic abutments, we have a titanium abutments, or we have a titanium base abutments. Now, starting with the ceramic abutments. Here is Miriam again, and she gave me later on, after about 5 years, where she was selecting then the ceramic abutment in this context. So for her, it was clear she wants to have everything in ceramic. And this was then at the end the reconstruction which we provided to her, where we have all single reconstruction, because she wanted to floss around each tooth. And we only had to kind of compensate for the missing tissue here in between the center and the lateral incisor with pink ceramic. So how stable are these ceramic abutments and ceramic reconstructions? So we have a lot of documentation regarding the fracture strengths and bending moments of all ceramic abutments. And when we compare them, we can always see that there is nothing better than titanium abutments. They are significantly stronger than ceramic abutments. And whereas the titanium abutment doesn't break, the implant breaks on the side of the ceramic abutment there the abutment breaks underneath the implant shoulders. So this was this typical situation also with Miriam. She wanted to have this all ceramic crowns also to the molar, and she was very happy with that. But after 5 years, she came with a loose crown. And we can see exactly what happened here, exactly that part below the implant shoulder fractured in that implant, which is also sometimes a little bit tricky to get them out. So this was the problem we were facing in the past. And then the companies were starting to think, hey, we have a solution. We're going to create a titanium-based abutments. And they are connecting then the reconstruction with the implant. And with that, we kind of increase on the one hand the mechanical properties, and we simplify the digital workflow. And in Switzerland, 66% of all abutments on the market, or abutments which are going to be bought, are titanium-based abutments. So they really came like a bomb. So we do have not yet that much data available, but we were really kind of motivated to look at the data of this titanium-based abutment because they came into the market without having a clear documentation. When we have here a study which has been performed by Alexis Ioannidis, and this is the situation before thermomechanical loading, where we have a nice gap there. And then after here, also we don't see anything here, there's actually zero gap. And after thermomechanical loading, which is about 5 years of function, we have gap formation there. And when we magnify these gaps, ladies and gentlemen, that's what we see there. And that was the case in about 1/3 of the cases. And I don't want to have such a gap in the most sensitive area of the implant, right in the biologic width. So this was then also something which stimulated us for understanding what happened on the level of the clinical situation. And we actually just have been able to publish the first 5-year result on titanium-based abutments. And when we look at the situation here, after 5 years, what did we find out? On the one hand, we had 24 patients which received trauma bone level implant, and we have placed then the 2-piece zirconia abutments. And here a typical case, what we did, and here how nice it looks like. After 5 years loading, we have good examples, but we also have bad examples where we have an amount of bone loss which we usually don't see at implants which have no risk factors. And even 2 implants were lost within the first 5 years, which leads to an implant survival rate of 91.7%. Ladies and gentlemen, there is no implant today anymore which accepts a survival rate which is so low. When we look at the different implants and all of them which have showed more bone loss, how can we see this? How do we see the resorption there? So with the group of Frank Josef Strauss from our department and Daniel Thoma, we were able, for the first time in history, that we really have a direct link between the prosthetic emergence profile and the restorative angle to the marginal bone level. So when we have a bone, an angle between the axis of the implant and how we come out there of less than 40 degrees, we have stable bone situations. But when it's more than 40 degrees, we have significant more bone loss. And that's what you also can see then in the data. So when we conclude regarding the mechanical stability, we can say the mean bending moment of restored titanium abutments was significantly higher compared to all tested ceramic abutments. That's clear. But titanium-based abutments increase the stability of the ceramic abutment reconstruction, but are not yet well investigated and may have some biologic risks. So that's important to understand. And here, the restorative angle of implant-supported crowns with titanium basis influences more mature bone level. So when we look at this situation, what are the real clinical problems in today's implant prosthetics when we look at these? So the titanium-based abutment was considered to be the problem solver. But when we look at it in more detail, we can say we have too many standard components with limited personalization. We have multiple components with multiple interfaces. I don't want to have all these interfaces within the most sensitive area. We have limited design flexibility because the titanium-based abutment gives us the emergence profile. Then we do need to cement, not clinically, but the dental technician needs to cement the crown on top of the titanium-based abutment. We have aesthetic disadvantages due to the titanium abutment and later on. We have more cost due to the additional component of manual cementation work. Therefore, the full potential of digital implant restoration cannot be exploited with today's implant connection. So the problem was that on the one hand, the implant companies developed top implants and with the mindset of improving the surface, getting better threads and so on. And on the other hand, there were teams working in the prosthetic world, but they have not been coming together. And this was then actually the chance of really having a personalized implant reconstruction with complete flexibility, no gaps. And this is actually one of the start of the personalized dentistry in implant prosthetics. Personalized dentistry means that we have that we tailored the medical decisions, therapies, inventions, and/or products to individual patients based on their predicted response. So when we actually consider how will be our future workflow in personalized dentistry, how that will look like, it starts that the patient can already use their cell phones to make a facial scan. So we don't need to have any more really fancy machines. Then the data acquisition can in the future also be done at home. Today we have these scan centers at different places, also at shopping malls. And then we do the planning, and we still have not yet seen the patient. We can do diagnostics and planning. And then potentially we can prefabricate the reconstruction. Then we can prepare the tooth through robotic execution. And at the end, we have a personalized prosthetic reconstruction, which we can use there. But how far are we away regarding these personalized solutions? When we have here now the matrix event of this newly developed implant crown interface, the idea was to have something where we have no titanium-based abutment, no cementation interface. We have a directly screw-retained 3D printed CAD/CAM implant reconstruction without any abutments. We have complete flexibility, and we have the same connection for single and multiple restorations. And before we have started in the clinic, we did two really extended in vitro stability measurements, one taken at the University of Munich with the Daniel Edelhoff, and one taken place in Zurich with Jenny Jerpe, where you can see we have complete flexibility regarding the form. We did then an in vitro study with the standard procedure as we have seen it before, with the other abutments having 4 different groups. On the one hand, the abutment-free group, then with the titanium-based abutments on the same implant and on a competitor titanium-based abutments and direct through retained. And then the thermomechanical age took place to a level of about 5 years. We had a 100% survival rate of the thermomechanical aging for every single study group. And when we look at the failure modes of this study mode, they differ. But the abutment-free abutment never fractured inside the implant, it fractured outside, as you can see it here. So the conclusion from that most important study was that number one, a novel implant crown interface specifically designed for in-house or laboratory-made, fully personalized CAD/CAM monolithic zirconia crowns. Similar failure loads compared to conventional implant abutment interface involving a prefabricated titanium base or certainly manufactured custom-made zirconia. And with this, we were really interested whether we have clinical data. We are currently running different studies, and one of the most famous one is this one here, where we are comparing actually two different groups, the test group and a control group. And the control group is exactly how it is done by today by using titanium-based abutments. Whereas on the test group, we have the direct connection there with no gaps, no cementation, no nothing, and completely individually designed. So we have the digital group and the test group and the control group. And this is the number of patients. And then we had the main inclusion criteria where it's a missing posterior tooth, premolar and molar. Now, how does the clinical workflow looks like with the characteristics here? And this is my very first case I did at the university. It was a very simple situation, a missing lower molar. And the dentist, which should have done the case, which I was assisting, was sick. So I'm using here the standard protocol to prepare the site for the matrix implant. And then using here the matrix implant, the soft tissue level implant with the nice pink color. Then a good visibility to apply the implant, as you can see here. Then the implant is going to be placed here at the correct prosthetic position. And then what allows you is that we can do an immediate scanning process, intraoral scanning process. We have here a impression coping, which you can use for conventional impressions or for digital impressions. There is no need for a scan abutment out of plastic. So here, I like that a lot. It's a titanium or a metal impression coping, can do the digital impression. I sent it to the lab, but they had no information. They were mirroring the neighboring tooth. And at the end, they printed me a crown, a PMA crown in this situation, just 30 minutes later. And these crowns, with any cementation, no steps in between, there's no need for doing a model. You can immediately place this crown. And it's a new way of personalized dentistry, which facilitates the process in a way I have never seen it before. This is then the implant position of this implant. And this is the temporary reconstruction, which I placed in there. And you can see here how ideally the situation is. And then later on, 3 months later, we placed then a monolithic zirconia crown here customized to the situation, which is basically a copy of what we have seen before. And here this has been placed. This is 12 months after loading with a very nice, also kind of stable bony situation. So the conclusion from that point of view is that newly personalized implant reconstruction without abutments will become an interesting alternative for titanium-based abutments. And future clinical studies are also needed to confirm these very promising results. Then we also need to talk about the biologic effects, because we have now a good evidence about the understanding of the different materials and the effect in the peri-implant tissues. There's one study performed at the University of Zurich with Sven Müllemann comparing monolithic zirconia crowns with porcelain fused to metal crowns. And here we could also see going back here, that we have significantly more inflammatory cells around the porcifused metal reconstruction compared to monolithic zirconia crowns. So the conclusion is that there is, on the one hand, from the attachment point of view, no difference between zirconia and titanium abutments. However, zirconia abutments seem to be have less peri-implant inflammation, and we have also less inflammation around monolithic zirconia crowns compared to porcifused metal reconstruction 6 months after loading. So here we do have an advantage on that side. And the last part is then the aesthetic part, where we'd like to talk about aesthetic measurements and aesthetic benefits, which we have here. Like this lady came with this situation, she was totally unhappy, and I provided her with new reconstruction and with this situation there. And we have learned in the past a lot about the evidence of peri-implant soft tissue aesthetics and the color situation. So today we have a much better understanding in terms of which situation can lead to a discoloration and which not. So at the end, we can say all ceramic crowns induce statistically significantly less visible color change compared to porcifused metal crowns regarding the neighboring teeth. And the major question is always, is there a critical mucosal thickness? Yes, there is. We did here a variety of studies. This is just the first out of this, which is a study in pigs, where we have titanium, titanium veneered, zirconia, and zirconia veneered. And we could hear for the first time, and this is a study which has very often cited worldwide, which could show that when we draw the line here by 3.7, which is considered to be everything which is above 3.7 is visible by the human eye, everything below is not visible by the human eye. When we have a mucosal thickness of 1.5 millimeters, we can see it with titanium, we can see it with titanium veneered, we can see it with zirconia and zirconia veneers, just a little bit. When we have a mucosal thickness of 2 millimeters, we can still see it with titanium, titanium veneered, but not anymore with zirconia. And with 3 millimeters, it doesn't matter what material we're going to use. So when it comes to critical mucosal thickness, it's everything which is thicker than 2 millimeters. There is no difference in terms of color changes between the different restorative materials. However, when it's 2 millimeters or less, we should consider an all ceramic reconstruction in order to avoid discolorations. Now, with this, we have an excellent background about the decision-making factors and the parameters. And now it's time that I'm going to provide you with a clinical concept, giving you really indications for each individual situation in the clinical part. When we look at today's dentistry, we can really be sometimes even shocked how far away we are from a personalized dentistry. These are two different patients. On the one hand, this is Naya. She's female. She's a waitress. She's a smoker. She's only 42 kilogram light and 156 kilogram tall. So she's really a tiny person. On the other hand, we have Dave, which is American. He's 29 years old. He's 127 kilograms and 205. And they both came as patient to me. And they both had the same gap there. And you know, they got the same implant. And at the end, they got the same crown based on a titanium-based abutment and a reconstruction top. And this is not anymore the today's dentistry. I think we really need to customize this and need to go in the direction of a more personalized solution. Why do they get the very same abutment and the same crown? So therefore, the matrix really helps us to enter now this new world of personalized dentistry. And based on this clinical concept, we look at each of our patients in a way to have either a patient which is more in the anterior area with a scallop change of morphology, or where we have a flat change of morphology. When we have a scallop change of morphology and we have an ideal implant position which allows to screw retain, and we have 1 to 2 units, then we have good evidence to use for zirconia abutments there. This is a case which I have done with 2 implants and the position of the central incisors. And these are 2 all ceramic abutments, which were directly veneered. That's the kind of the way we're going to solve these parts. And here we have a good documentation that this is working. However, not every implant system allows this, and not for every implant system the evidence is so good. That's why the titanium-based abutment came into the market. And here we have a case which I did the implants for a colleague, Alessandro Revigos, which is a champion in CEREC. So he does everything with the CEREC system. So I placed the implant, I put the provisional crown in, and then he wanted to make a lithium disilicate crown directly chair side on this titanium-based abutment. And then he had difficulties to place it and made an X-ray. And then he called me, hey, Ronnie, I don't get these implants in place. What's happening? Now, when we look at the situation, this was my temporary reconstruction, very slim in this area. And that's important to be slim there. Versus here, where it's so much bigger. And then we have the, at the mesodistal point, we have the crestal bone here in touch. So these implants, they often don't get in place. So we really don't want these titanium-based abutment in a scallop situation. There, we prefer to have really then the either implant systems which allow for all ceramic reconstructions, or we want to have the matrix implant allowing for a completely personalized solution, like these two central implants by Joel Teles, which did a beautiful work here by having two crowns, which were also all ceramic zirconia crowns, just veneered on the buccal aspect. And you have all options in terms of the emergence profile there to get a nice reconstruction. So that's how we would like to have our implants in the future. So when it comes to a scallop situation, we would like either a customized screw reconstruction made of all ceramic, but actually we don't want to have titanium-based abutments. There we would prefer to have then the matrix connection in this area. Now, when we have more than 3 units, today the standard is still kind of using porous-fused metal reconstruction, like this lady here, which had a huge defect here. We made a bridge. This is where we have the evidence from at the moment. But we don't like to do these type of reconstructions anymore because on the one hand, we have heard about the biologic situation and they're so cost intensive because of the high gold price. Because of that, again, the titanium-based implants, they entered the market because they were so much cheaper. Like here a case, which I did in interior area with 4 implants, and again, also a zirconia bridge, full zirconia, monolithic, just veneered on the buccal aspect there. You can see it here on titanium-based abutments. And this was the situation here. So when it's not too scalloped, that works with the titanium-based abutment. But you have seen about the biologic risks there. Therefore, for me, also the future would be to really use the matrix connection in these multiple tooth gap. And that's the good thing because we can use the matrix connection for single, but also for multiple reconstruction. When you're not in an ideal implant position, when the implant axis is really very bad, as we can see it here, we cannot screw retain it, then there is no way around for a cemented reconstruction, either out of titanium or out of zirconia. And again, don't forget about what we have learned from Ager. When we have a shoulder, which is 1.5 to 3 millimeters subtangent, we are not able to completely remove the cement. So it should not be deeper than 1 to 1.5 millimeters. When we are more in posterior area with flat change of morphology, ideal implant position, 1 to 2 unit today, it's a titanium-based abutment. But for me, the future is there that we use the matrix abutment as we do it here in the clinic. Here another case by one of our postgrad students, again, ideal situation there, again, a case which has then been immediately provisionalized with a PMMA crown, just directly milled thereafter, and with not a need of any cast, we can just place it in here. This is the temporary reconstruction. We can see some bone remodeling in that part. And this is then the 3 months later, a copy of the PMA crown. Now here a little bit more artistic with a lot of staining. I was surprised that patient allowed to do this. And this is the situation now later on. And this, you can see here the 3-month result, where we have here still some bone remodeling. And after 12 months, we have really a very nice bone fill up this area. So again, here in the posterior, yes, titanium-based abutment, they work. Again, we have not yet so much documentation, but the matrix is for me the future there, but also here we need to have further documentation. For more than 3 unit gaps, this is the same as we have seen before. Porous fused to metal reconstruction would be the choice, but due to the price, we would like to go here also for a matrix connection because they allow much more. And then when it's in the posterior with an area where we are really outside the possibility to screw it in, there we're going to use titanium abutments individualized in a way that they're not deeper than 1 to 1.5. Now with this decision tree, you basically cover all the indications we have in clinics. And with this, we also solved the problem with Steve, because we were able to really provide him with a all ceramic reconstruction here on this central implant with a cantilever to the lateral incisor. And he was very happy with the situation. And then he went back to Florida again, where he follows his passion and his sport, where he does his jumps there again with his teeth. And with these beautiful pictures, I would like to thank you very much for your kind attention. And again, thank you very much for having me here in Hong Kong in this online world. Thank you very much.